This lecture is on the hypertensive disorders of pregnancy. Hypertension is the most common medical disorder of pregnancy, and it affects anywhere between 6 and 12% of all pregnancies. It is a leading cause of maternal mortality, and as well as being damaging to the parturient, it also is an important risk factor for fetal complications, including preterm birth, fetal growth restriction, and fetal and neonatal death. These hypertensive disorders encompass a range of conditions that include chronic hypertension, gestational hypertension, preeclampsia, that includes both preeclampsia without severe features as well as preeclampsia with severe features, and could also include preeclampsia superimposed on chronic hypertension, and then could lead to eclampsia. Despite the clinical presentation being quite similar for all of these types of hypertensive disorders, in 2013, the American College of Obstetricians and Gynecologists developed a task force on hypertension in pregnancy that not only regulated or updated the diagnostic guidelines, but developed therapeutic guidelines for treating the hypertensive disorders in pregnancy. So let's first talk about the different classifications of hypertension in pregnancy. Well, first is chronic hypertension, and that just merely involves either a pre-pregnancy systolic blood pressure greater than 140 or a diastolic greater than 90, or that this hypertension presents itself at less than 20 weeks gestation. So we're talking about an underlying or previous condition prior to pregnancy. Gestational hypertension, which is the most frequent cause of hypertension during pregnancy, presents as elevated blood pressure after 20 weeks gestation, but it's without any other underlying signs and symptoms, so with the absence of proteinuria or any kind of systemic signs. With mild gestational hypertension, it results in outcomes that are pretty much similar to those of normotensive pregnancies. However, when it's severe, it can definitely result in a lot of adverse outcomes that sort of mirror how preeclamptic or the risk of a preeclamptic patient. The lines of diagnosis between gestational hypertension and preeclampsia are kind of blurred. Oftentimes, gestational hypertension isn't definitively diagnosed until after pregnancy or after the fetus is delivered. So it's kind of a diagnosis of deferment, if you will. In many cases of gestational hypertension actually lead to preeclampsia. Moving into our more clearly defined hypertensive disorders of pregnancy, first we come to preeclampsia without severe features. This used to be known as mild preeclampsia, but ACOG didn't really like the idea of calling anything in pregnancy mild, so we now call it preeclampsia without severe features. And the diagnostic criteria includes a systolic blood pressure greater than 140 or a diastolic pressure greater than 90 that usually occurs after 20 weeks gestation, and proteinuria. Now, as you can see, there's a little asterisk next to proteinuria or worsening proteinuria there in the notes, because current recommendations state that clinicians should also consider the diagnosis of preeclampsia in the absence of proteinuria when any of the following signs are also present. You can see the list there: low platelet count, less than 100,000, elevation of liver enzymes, elevated serum creatinine, any kind of cerebral or visual disturbances, as well as a presentation of pulmonary edema. Other symptoms that may occur with preeclampsia without severe features include a decrease in urine output. Patients may present with generalized edema, mild headaches, nausea, vomiting, abdominal pain, chest pain, a depression of patellar reflexes, as well as IUGR. Severe preeclampsia, or preeclampsia with severe features, I guess I should say, is a patient who presents with a systolic pressure of greater than 160 or diastolic greater than 110. And these measurements have to be obtained somewhere between 15 and 60 minutes apart. It's kind of different based on different guidelines. But in addition to that, a patient that presents with persistent oliguria and has some kind of progressive renal insufficiency. Other symptoms that they may present with include an unrelenting headache, partial blindness or blind spots, epigastric or right upper quadrant pain, pulmonary edema, and again, a very low urine output. These patients generally have even worsening creatinine as well as proteinuria, and also can have nausea, vomiting, abdominal pain, the same symptoms as preeclampsia without severe features. So, not a disease to be taken lightly. Some of the most serious complications of preeclampsia include stroke, hepatic failure, renal failure, placental abruption, DIC, HELP syndrome, which we'll talk a little bit about later, as well as severe pulmonary edema and airway emergencies. So the incidence of preeclampsia in the United States is somewhere between 4 and 8%. And again, like I said before, it is the leading cause of preterm labor and delivery. And delivery of the infant and the placenta is the only effective treatment or cure, if you will, of preeclampsia. The leading risk factor for preeclampsia is nulliparity.
And then secondly, limited preconceptional exposure to paternal sperm is also a risk factor. So that's why it's commonly seen in teenage mothers or women who were conceived with donated sperm, or parous women who've conceived with a new partner, or women who've used barrier methods of contraception prior to conception. And next, a risk factor, a partner-related risk factor, is conceiving with a partner who fathered a preeclamptic pregnancy in another woman. So next we have non-partner related risk factors, and that's a history of preeclampsia in a previous pregnancy, advanced maternal age, a family history of preeclampsia, having a history of placental abruption, intrauterine growth restriction, or fetal death, or having a non-Hispanic Black racial background. In addition to that, Black women with severe preeclampsia demonstrate more extreme hypertension and usually require more antihypertensive therapy, and unfortunately have a higher mortality rate from preeclampsia. So maternal disease-related risk factors are obesity, which is a primary risk factor, and the risk escalates with increasing BMI, underlying chronic hypertension pre-pregnancy, diabetes, and thrombotic vascular disease. Behavioral risk factors, cigarette smoking actually shows to have a risk reduction in preeclampsia. So the pregnancy-associated risk factors are risk factors that are associated with rapid uterine enlargement, things like multiple gestation or polyhydramnios or hydatidiform mole. So what causes preeclampsia? Well, the exact pathogenic mechanism that's responsible for the progression of preeclampsia is not actually known. There are a lot of theories that exist, though. And surrounding all these theories, the focus of the disease is the placenta, or what is sometimes referred to as the critical mass of the placenta that needs to be present in order to cause preeclampsia. So in normal pregnancies, spiral arteries of the myometrium lose muscular wall and become distended. In preeclampsia, they don't actually lose this muscular wall and they remain constricted. This results in increased uterine vascular resistance and causes up to 30 to 40% of a decrease in uterine blood flow. So there are a lot of theories that people look at and a lot of theories that have been rejected over the years, but the most widely accepted theory is that the placenta fails to embed adequately. And in response to hypoxia, which is caused by poor placental perfusion due to this increased uterine vascular resistance, the placenta releases factors into the circulation that damage maternal endothelium and give rise to the multisystem manifestations of preeclampsia. So that's the abnormal placentation part of it. Another possibility or another influence are genetic factors. And this is a complex component, but it's highly likely because of the incidence of preeclampsia in multiple family members. And lastly, there seems to be some immunologic factors, especially because, like I talked about earlier, the evidence that suggests that long-term exposures to paternal antigens in sperm is protective. So what are the signs and symptoms of preeclampsia? So in your notes here, you can see I have a table titled Organ System Derangements in Eclampsia. So let's start out with cardiovascular. Vascular hyperreactivity seems to be the most important characteristic of preeclampsia, and this is what leads to maternal hypertension and reduced placental perfusion. This vascular hyperreactivity leads to an increased SVR, which can lead to a left ventricular failure and possibly even pulmonary edema. The pulmonary system, these patients are also at risk for pulmonary edema due to a decreased colloid osmotic pressure, due to urinary loss of albumin, and increased capillary permeability, which leads to interstitial accumulation of fluids in the lungs. These patients have an exaggerated response to IV fluid administration and are at very high risk for a difficult airway due to all the edema in the upper airway and larynx, which is normal in pregnancy and can be exaggerated in patients with preeclampsia. Preeclampsia is associated with a decreased renal blood flow and glomerular filtration rate. These patients have difficulty with clearance of drugs metabolized by the liver due to their abnormal liver function, and hepatic hematomas and even a hepatic rupture is a possible complication from preeclampsia. These patients often present with a decreased plasma volume, and it's not uncommon for them to have thrombocytopenia, which we'll talk more about later. This can lead to an increased blood viscosity, and this severe hypovolemia results in hemoconcentration, which can sometimes mask the underlying anemia. The preeclamptic patient is prone to vasospasm, which can cause visual disturbances, headaches, hyperreflexia, as I said before, and potential complications include cerebral edema and cerebral hemorrhage. 3 possible treatments have been proposed to prevent preeclampsia. The first being starting the patient on low-dose aspirin. Low-dose aspirin has been proposed for the prevention of preeclampsia on the basis that thromboxane levels and prostacyclin levels are exceedingly high in preeclamptic patients, and aspirin inhibits the synthesis of these prostaglandins. Calcium supplementation has been studied for preeclampsia prophylaxis on the basis of observations that dietary calcium intake and the incidence of preeclampsia have an inverse relationship. And lastly, antioxidant supplementation has been investigated because of the oxidative stress observed in preeclampsia. So how do we treat preeclampsia? Well, the general aims of therapy are to treat hypertension, minimize vasospasm to improve the circulation, particularly to the placenta, uterus, and kidneys, to have close fetal and maternal monitoring, to prevent seizures, to continuously evaluate and plan for the timing and route of delivery based on maternal and fetal condition, and to administer corticosteroids if preterm delivery is imminent. The only cure for preeclampsia is delivery of the fetus and placenta. So bed rest and close monitoring until around 37 weeks is usual unless the status of the mother and fetus deteriorate.
So during the time period when preeclampsia is diagnosed and delivery of the fetus is a viable option, then we need to treat the hypertension. And not only is treating the hypertension important, but a timely initiation of starting those antihypertensives is very critical. There's been a lot of research that shows that the shorter the interval of time between the diagnosis of preeclampsia and the start of antihypertensives, then the greater the positive outcome or the decrease in morbidity and mortality.
So this next table gives you some of the drugs that are used for the treatment of severe hypertension in pregnancy. There's a large variety of drugs that are used, and primarily you're going to see hydralazine and labetalol used. Hydralazine because not only does it reduce maternal blood pressure, but it increases uterine blood flow simultaneously. It does have a slow onset, which limits its use. However, it's still one of the safest drugs to use in this case. Labetalol, again, often used. Calcium channel blockers, particularly nifedipine, are gaining importance as safe and effective antihypertensives in pregnancy because they decrease afterload and uterine musculature, which decrease the risk of preterm labor. They also increase renal blood flow. However, great care has to be taken when it's being used in conjunction with magnesium sulfate due to the synergistic reaction, and there's a high risk of cardiovascular collapse. Also remember that calcium channel blockers prolong neuromuscular blocking drugs.
Another option in decreasing blood pressure is using sodium nitroprusside. Now, this would be only utilized in emergency situations and in patients that hydralazine and labetalol and potentially nifedipine and nicardipine are not working for. Additionally, it would only be used for very short-term, as a short-term solution because of the risk for fetal cyanide toxicity if it's used for a long period of time. And then I have Esmol listed on here last. Esmol is kind of a controversial drug in preeclampsia. The current ACOG recommendations state that only should be administered by an anesthesia provider, so it's not in a toolbox of the obstetric RN, if you will. And it's primarily because it can cause transient fetal bradycardia. More recent studies have shown that there's not an incredible incidence of that, and as long as we're monitoring the fetal heart tones closely, that it doesn't put any significant morbidity on mother or baby. So again, because esmolol is so short-acting, it would probably be used for very short-term periods of time until we could get something like hydralazine working. So we've talked a lot about the management of preeclampsia, but what are we actually managing or working towards? Well, not only are we working to, of course, decrease morbidity and mortality until we can actually deliver the fetal placental unit, but we are also working to prevent eclampsia. And eclampsia is simply defined as the new onset of seizures or unexplained coma during pregnancy or in the postpartum period in a woman with signs and symptoms of preeclampsia and without any kind of pre-existing neurologic disorder. So simply stated, seizures associated with pregnancy-induced hypertension. So I don't need to state the obvious that a pregnant patient having seizures is very dangerous, but there is actually an 11% maternal mortality rate associated with a parturient having a seizure outside of the hospital. And the incidence of seizures is distributed evenly in the pre, intra, and postpartum period, so it can happen at any time. So in addition to using those antihypertensive medications in preeclampsia, there is also a very large body of evidence that shows in severe preeclamptic patients that seizure prophylaxis is going to be very important. So hoping to prevent that progression of preeclampsia into eclampsia. And we do that by using magnesium sulfate therapy.
So it's the best available agent for the prevention of recurrent seizures in women with eclampsia. Normal magnesium level is 1.4 to 2.4, and the therapeutic range for a patient with preeclampsia or eclampsia is 5 to 9. It's excreted by the kidneys, and there is a potentiation of a neuromuscular blockade when a patient is on magnesium sulfate. Magnesium sulfate acts by causing generalized CNS depression. It dilates the cerebral arteries to prevent ischemia, and it has mild antihypertensive effects and also tocolytic effects, so it will decrease the incidence of preterm labor. It's a really great drug, but it has some serious side effects. Some of the side effects include nausea, chest tightness, palpitations, blurred vision, sedation, transient hypotension, and very rarely pulmonary edema. Next, when a patient is on continuous magnesium therapy, we need to be watching for signs of hypermagnesemia. And this is why you'll see nurses walking around with reflex hammers in their pockets, the OB nurses. So in order of progression to severe hypermagnesemia is decreased deep tendon reflexes, warmth and flushing, EKG changes, somnolence, loss of deep tendon reflexes, heart block, respiratory arrest, all the way up to cardiac arrest.
The treatment of magnesium toxicity is, of course, calcium gluconate, and we would give 1 gram IV over about 3 minutes, and you can repeat that dose as needed. If you don't have calcium gluconate, it is advisable to use calcium chloride, but you would have to use 500 milligrams of calcium chloride IV over about 5 to 10 minutes. Contraindications for magnesium therapy include parturients who have cardiac conduction abnormalities for obvious reasons, patients who have severe renal dysfunction or renal failure. It can still be used in patients who have renal insufficiency, but they should certainly be monitored very closely because toxicity can happen pretty quickly. And patients who have myasthenia gravis also should not receive magnesium therapy. So outside of mag sulfate, we have other options for if we are faced with a patient who starts seizing. And of course, those are things like Ativan, Valium, Versed, Dilantin, as well as propofol in an emergency situation. We talk about seizure management. Of course, you're going to maintain airway patency, ventilations, you're going to follow the ABCs. Of course, protecting the patient from injury, all the while trying to maintain that left uterine displacement because of the importance of perfusion to the fetus. You're going to be assessing neurologic function, and then as quickly as possible, utilize medications to provide acute seizure control until you can get that magnesium therapy on board. So that might mean giving a little bit of IV propofol or Versed up until you can get that therapeutic level of mag sulfate. Another potential occurrence in the preeclamptic patient is something called HELP syndrome. And HELP stands for hemolysis, elevated liver enzymes, and low platelet count. So that's where the HELLP comes in. It occurs in somewhere between 4 and 12% of preeclamptic patients, and it can actually occur either before the hypertension and proteinuria show up or even without hypertension and proteinuria present. So some groups actually view HELP syndrome as something completely different diagnosis from preeclampsia, but we tend to see them hand in hand more often than not. In the patient with HELP syndrome, a diagnosis of HELP is usually an indication for immediate delivery, regardless of gestational age, because the potential for mortality. Platelet counts can fall very quickly in the face of HELP syndrome, and should definitely be evaluated in anyone who there's a potential question that they may have HELP. Platelet count should definitely be done prior to the instrumentation of any kind of neuraxial anesthesia. Obviously, in this patient population, postpartum hemorrhage or antepartum hemorrhage is a significant risk, and so preparation for large amounts of blood loss should definitely be instituted prior to either vaginal delivery or a cesarean section.
So let's talk about the anesthetic management of the preeclamptic patient. Providing analgesia or anesthesia for patients with preeclampsia can be very challenging. The anesthetic management of the woman with mild preeclampsia differs little from the management of a healthy pregnant woman. However, it's important to recognize the potential for mild preeclampsia to rapidly progress into a severe form of the disease. It's important to carefully consider the issues specific to the disorder and their potential interaction with the anesthetic management. Continuous labor epidural and combined spinal epidural are the preferred methods of pain management in the patient with preeclampsia. In addition to that, the early administration of an epidural is recommended. The advantages to that are you can obtain high-quality analgesia, which attenuates the hypertensive response to pain. It helps to reduce circulating catecholamine levels. It possibly improves intervillous blood flow. And it's sort of an insurance policy that if you have a labor epidural in place, it can be used for an emergency section or for instrumental births, such as forceps or vacuum deliveries, which women who have preeclampsia have a higher incidence of. In addition to that, practically speaking, it's easier to insert a catheter into the epidural space if the patient is not writhing in pain, which predictably increases in intensity as labor progresses. Now, one disadvantage of actually using a combined spinal epidural for analgesia is that the epidural catheter function can't actually be fully evaluated until after the intrathecal analgesia resolves. And so because of this, a lot of anesthesia providers will avoid the CSE technique in favor of just a standard epidural technique in women who have severe preeclampsia because of their higher risk for emergency cesarean section. So if you utilize a standard epidural technique, then you can immediately verify how well that catheter is functioning. So in addition to doing a complete preoperative assessment on a patient prior to instituting any kind of neuroaxial anesthesia, there are a few issues specific to this disorder that you should consider, and that's that you should assess coagulation status. Because coagulation disorders can occur in preeclampsia, this must be assessed prior to instrumentation of the neuraxis. A concealed hemorrhage would have a disastrous outcome in these patients. Secondly, intravenous hydration considerations. Preeclamptic patients are prone to exaggerated bouts of hypotension with an induction of sympathetic block. On the other hand, overaggressive intravascular hydration can quickly lead to pulmonary edema because of their decreased plasma colloid oncotic pressure. When you're administering regional anesthesia, it's helpful to titrate the local anesthetic slowly to avoid a precipitous decline in blood pressure. And if you do have to treat hypotension from the sympathetic blockade, it should be accomplished judiciously because the vasculature of these patients can be very sensitive to exogenous pressors. And lastly, you should avoid the use of epinephrine-containing local anesthetic solutions because of their sensitive response to those exogenous pressors. And this includes your test dose that has epinephrine in it. So now we'll move on to cesarean delivery. With a patient who is going to be delivered via C-section, the pre-anesthetic evaluation should include assessment of target organ system involvement with a heavy focus on the patient's airway exam, maternal hemodynamics, and coagulation status and fluid balance. You want to have good hypertensive control, and like I said before, pay close attention to the possibility for intravascular depletion. You want to assess the degree of oliguria, probably check a creatinine level and liver function tests, and coagulation status should be a top priority to you. You're going to want to assess not only platelets, but PT and PTT, possibly fibrinogen, possibly FSP. Is this patient on mag sulfate therapy? If so, what's the dose? And when was the most recent level checked? And how does the patient being on magnesium sulfate therapy affect your choice in anesthesia? And lastly, a very thorough airway assessment is of the utmost importance to you. So we've established that patients who are preeclamptic are very high risk and potential for complications is very high. And there's multiple reasons why. Because of their poorly controlled hypertension, they're at high risk for intracranial hemorrhage, they're at high risk for complications due to an increased urinary protein, because they have thrombocytopenia, because of their depleted central vascular volume, and because of a high association with chronic hypertension and diabetes. Although the use of a continuous arterial catheter is not mandatory, it would be highly recommended for the following reasons. If the patient has sustained diastolic blood pressure greater than 90 or really labile blood pressure, if you need to use parenteral vasodilators such as nitroprusside or nitroglycerin to control blood pressure for an inability to obtain an accurate blood pressure by a cuff, or if there's a need for frequent blood sampling. CVP monitoring is not routinely used, however, should be instituted in the case of severe hypertension that's unresponsive to conventional treatment, in the case of severe pulmonary edema, or in the case of persistent oliguria unresponsive to fluid challenges. And so now you have a preeclamptic patient who's going to go to C-section. What are you going to do? General anesthesia, spinal anesthesia, or epidural anesthesia? Well, let's talk about the three choices and the advantages or disadvantages to each. If preeclampsia is mild, like we said before, standard anesthesia practice is fine. However, in someone who's severely preeclamptic, regional anesthesia, always in obstetrics, is preferred. However, if a coagulopathy is present, get your laryngoscope handy because you're going to be using it. Now, if regional is okay, what would you like to use? Subarachnoid block or your labor epidural? Well, there are actually no studies that show that a labor epidural or an epidural is better than a subarachnoid block. However, there are studies that show that more fluid needs to be given in patients who receive a subarachnoid block versus dosing an epidural. So because an epidural can be dosed slowly, those wide swings in blood pressure can be easily avoided and fluids can be titrated a little more careful. So advantages using epidural for C-section: it blunts the hormonal and hemodynamic responses, provides better hemodynamic stability than spinal or general anesthesia. It increases renal and uteroplacental blood flow. You have a decreased potential for seizures, and like I said, it's able to be dosed slowly. Now, traditionally, the view has been that spinal anesthesia is relatively contraindicated in patients who have severe preeclampsia due to the possibility of severe hypotension due to the rapid onset of spinal anesthesia. However, based on the results of more recent studies and clinical experience, there's growing support for its use in preeclamptic women. Naturally, it is less hemodynamically stable than an epidural. However, you do have less potential for hematoma because the spinal needle is so much smaller than the epidural. And in a pinch, when you have time constraints and you're taking a patient emergently for a C-section, when given the choice of spinal or general anesthesia, I would certainly think you would choose a spinal anesthetic to avoid the risk associated with an emergent administration of general anesthesia. Now, although it's less than desirable, there are going to be times when general anesthesia is your only option for the preeclamptic patient. It would be used in cases of coagulopathy or in fetal distress when there's no time to place neuraxial anesthesia. These patients are at very high risk for a difficult airway. In addition to that, swings in blood pressure can be very detrimental to these patients and the fetus. Acute hypertension, patient runs a risk of hemorrhage. Acute hypotension, patient runs a risk of placental hypoperfusion. This is something that needs to be taken into consideration when you're making your induction agent choices. It's generally advised to use propofol for the induction of anesthesia on these patients, in addition to succinylcholine. Pretreatment is generally unnecessary if these patients are on magnesium sulfate. And if you are going to use a non-depolarizer, you probably want to use a reduced dose of a short-acting non-depolarizer. Induction agents to avoid ketamine because it can aggravate your hypertension. It's possible these patients might need an arterial line and probably will require a second IV. And you're also going to have smaller than normal sized endotracheal tubes available, in addition to any equipment that you might need for the management of a difficult airway. Because acute swings in blood pressure can be so detrimental to these patients, like we were saying, the hypertensive response that can easily lead to increased intracranial pressure and hemorrhage, you probably want to consider administering a beta blocker prior to events that may lead to a hypertensive response, i.e., induction, intubation, and extubation. It's also important to recognize that postoperatively, these patients aren't out of the woods by any means. Magnesium sulfate therapy should be maintained postoperatively, and the patients still need to be closely monitored. In normal pregnancy, the postpartum period can produce dramatic fluid shifts. So these can be very dangerous in patients with preeclampsia, and they are still at high risk for pulmonary edema in the postpartum period. So let's talk a little about thrombocytopenia and neuraxial anesthesia. What is the safe lower limit for platelet count before you place an epidural? Well, this is kind of a long debated topic amongst practitioners, and most people will agree that the trend of the platelet count is more important than the actual platelet count result. There is a study that's often quoted from 1989 that Rasmus did, in that it was a retrospective analysis of almost 3,000 parturients, and there were 14 with a platelet count between 18,000 and 90,000 that received neuraxial blockade. And there was actually no problems or no incidence of spinal hematoma that was reported. Having said that, most people follow somewhere near these recommendations. They want to get a thorough patient history, check for any kind of signs of bleeding, and get a platelet count. If the platelet count is greater than 100,000 and there are no other signs of bleeding present, you can proceed with neuraxial anesthesia. If the platelet count is less than 100,000, then there needs to be a little further investigation, and that may be when someone decides to get a PT, a PTT, fibrinogen. Some practitioners will tell you that their cutoff is around 80,000. However, most will agree that a platelet count less than 50,000, they are not going to get any kind of neuraxial anesthesia. And if that patient goes to C-section, again, have your laryngoscope handy. Now, not only are these recommendations important for the placement of a catheter, but for the removal of the epidural catheter. So it's important to recognize that the risk of epidural hematoma formation exists not only with the placement of an epidural, but with the removal of that catheter. And so it's important to continue lab draws postpartum also. If the decision is made to proceed with the neuraxial technique, the following suggestions may help reduce the risk of epidural hematoma. That's first, the most skilled anesthesia provider available should perform the neuraxial procedure. This, of course, prevents multiple needle passes. A spinal technique may be preferable to an epidural technique when it's appropriate because of the smaller needle size. Now, this, of course, isn't going to play into effect when you're talking about doing neuraxial anesthesia for labor, because generally the epidural is going to be the preferred method. Third, use of a flexible wire-embedded epidural catheter may reduce epidural vein trauma. The patient should be carefully monitored after delivery for neurologic signs that may signal bleeding into the epidural space. Next, the platelet count should be checked for evidence of a return toward normal measurements, at least 75 to 80,000, before removal of the epidural catheter. And last, imaging studies and neurologic or neurosurgical consultation should be obtained immediately if there's any question of an epidural hematoma.